Bladder cancer radiotherapy is challenging due to the bladder's mobility and deformability, necessitating large treatment margins that increase radiation exposure to healthy tissues. Image-guided radiotherapy improves targeting by using real-time imaging such as cone beam CT to visualize soft tissue. Adaptive radiotherapy builds on IGRT by adjusting daily treatment plans based on bladder anatomy, reducing treatment volumes by up to 40% while maintaining robust tumor coverage. Here, the RAIDER trial randomized 345 patients with T2 to T4A unifocal muscle-invasive bladder cancer into 3 groups. Whole bladder radiotherapy, which was delivered at 55 Gray in 20 fractions or 64 Gray in 32 fractions. Standard dose adaptive radiotherapy, which was delivered using the same doses as WBRT, however also used adaptive planning to reduce the margins. Finally, dose-escalated adaptive radiotherapy delivered escalated doses of 60 Gray in 20 fractions or 70 Gray in 32 fractions. The primary endpoint was radiotherapy-related late toxicity, greater than or equal to grade 3, between 6 and 18 months post-treatment. Secondary outcomes included bladder intact event-free survival, local regional control, and overall survival. With a median follow-up of up to 42 months, grade 3 or greater late toxicity was reported in 1.7% of 20-fraction DART patients and 0% of the 32-fraction cohort. Next, grade 2 or greater late toxicity was observed in 31% of 20-fraction DART patients and 36% of the 32-fraction cohort. Moreover, 2-year cumulative grade 3 or greater toxicity was reported in 2.4% of patients for 20-fraction and 1% of patients in the 32-fraction cohort. 2-year bladder intact event-free survival was 72% for DART and 67% for WBRT and SART. Local regional disease control was achieved in 74% of DART patients, and overall survival was 80% for DART versus 77% for WBRT and SART. To conclude, the RAIDER trial confirms the feasibility of dose-escalated adaptive radiotherapy, achieving strong tumor control with minimal late toxicity. Late grade 3 or greater toxicity rates were exceedingly low, reflecting the safety of the adaptive techniques. However, similar to the BC 2001 trial, reducing high dose volumes did not conclusively reduce bladder toxicity, suggesting that global bladder dose may be a less critical determinant of toxicity than previously thought. Future advances such as real-time adaptive techniques using MRI or CT with functional monitoring could further enhance bladder sparing. The study's non-comparative design and small sample size, compounded by lower than expected overall toxicity, limit definitive conclusions. As the trial was not designed to compare treatment groups directly, further randomized studies are needed to validate these findings and refine adaptive radiotherapy for broader clinical applications.